Good evening, everybody. I'm Dr. Abhenil Mittal. I am currently working as a clinical research fellow in breast and genitourinary oncology at the Princess Margaret Cancer Center, Toronto, Canada. It's a privilege to be here tonight presenting among this esteemed audience. I would like to thank Dr. Sudeep Gupta and Dr. Shona Nag for the opportunity to be here today. The first paper I'm going to present is actually my own publication. It was my DM dissertation while I was a student at AIIMS New Delhi. It is titled as a profile of pathogenic mutations and evaluation of germline genetic testing criteria in consecutive breast cancer patients treated at a North Indian tertiary care center. A bit of a background. These were the two seminal papers which were published in 2018 by Beach et al. And Yang et al. Both of these papers found that the NCCN criteria actually missed almost half of patients who were eligible for germline genetic testing. Post these publications, the American Society of Breast Surgeons actually issued a statement stating that all patients with breast cancer should be tested. This debate now has been ongoing in the oncology community for the past 3 or 4 years, and it has become even more relevant with the publication of data for PARP inhibitors, both in the metastatic setting as well as in the adjuvant setting. However, all of this data is from the West, and prior to publication of a study, we had no such data from the Indian population. So we did design a simple study. What we did was we recruited all patients with the CA breast who attended our clinic over a 1 year period. After obtaining informed consent, we qualified them as being NCCN qualifiers or non-qualifiers. We also applied the MCG criteria, which is basically the mainstreaming cancer genetics criteria, and are used uh, uh, in UK. They were first published by Dr. Kemp from the Royal Marsden Hospital. After pre-test counseling, all patients underwent genetic testing by next-generation sequencing and reflex MLPA. Risk management was decided by results of the genetic testing. So we eventually recruited 236 patients. The median age in our study was 45 years. Which is corresponding to the previous studies from the Indian population. 35% of our population had triple negative breast cancer. Overall, we found the prevalence of pathogenic mutations in our cohort to be high at 18.64%. About 30% of these were mutations in the non-BRCA genes. Interestingly, only one patient had an Ashkenazi Jewish founder mutation. I'm sorry. There were no recurrent mutations detected. This is a pie chart showing the various genes in which we found mutations. BRCA1, as expected, was the most common, followed by BRCA2. Other important findings that we saw were almost 70% of patients qualified NCCN criteria for testing, and majority by virtue of age being less than 50. We did see that patients who qualified NCCN criteria had a higher chance of having a pathogenic mutation. However, even in those patients who were not qualifying criteria, almost 7% had a pathogenic mutation. These patients would have been missed if we had only tested according to criteria. Overall, the sensitivity of NCCN criteria was 88.6%. We could reach a sensitivity of more than 95% if we relaxed the age cutoff of criteria to 60 years. About 37.38% of our patients underwent risk-reducing interventions in the form of either a risk-reducing mastectomy, salpingoophorectomy, or both. Unfortunately, only 10% of eligible previvors underwent cascade testing. That is at least 1 in 38% of families, and we were able to identify 23 unaffected previvors. But when we analyzed sensitivity of the criteria at various ages, we found that we could reach a sensitivity of more than 95% at 60 years and more than 90% at 55 years. Recently, Yadav et al. Had published their data and had done a similar sensitivity analysis where they could reach this cutoff at 65 years, indicating that we could reach this cutoff basically a decade earlier. Practically, by testing 22 additional women between 55 to 60 years, we could identify 5 more mutations. So we concluded that a high prevalence of PLP mutations was found in a prospective breast cancer cohort, and this was almost double than what has been previously reported in Western literature. Patients qualifying NCCN criteria were more likely to have a PLP mutation. However, a significant proportion of patients were missed by these restrictive criteria. Uptake of risk-reducing interventions was lower as compared to Western studies, and there was a lower than anticipated uptake of cascade testing. This is just a table of comparing various international studies which have, uh, identified various pathogenic mutations. And as you can see, most of these are in the range of 5 to 10%, except the study from Nigeria, where almost 15% of patients had a pathogenic mutation. This is likely in accordance of having higher proportion of triple negatives, like in India. This is the previous Indian published data, where almost 30% of patients have had a previous pathogenic mutation, but most of these studies are laboratory based and suffer from selection bias. None of these are prospective studies. There are various points which we need to, discuss regarding what we need to do for our patients. The first is obviously the optimal testing strategy. Should we test all patients? Should we test all triple negatives? Or should we test everybody up to the age of 60 years and follow criteria based testing for everybody older than 60? This is a hybrid approach which has recently been proposed by a number of groups, including Yadav et al. From Mayo Clinic, as well as in a recent paper by Dr. Nadine Tang. It is reasonable as well as attractive. However, this is based on data from the West, where the prevalence of pathogenic mutations in patients above 65 years is about 1%, which is similar to the normal population. We do not have that data available from India, as there were very, very few patients above 65 years in our study. And we need to generate that data first before we make any firm conclusions regarding that. The other issue with the testing includes increase in VUS and how to tackle this. As we get more data, this is expected to go down. The third issue remains optimal strategy for moderate penetrance genes. There is some upcoming data for patients who have a mutation in PALB2 gene and an ATM gene. However, we need more data for others. We need to focus on improving uptake of cascade testing. And lastly, it is extremely essential to have access to drugs and family screening, so that when we have genetic information, we are able to do something about it. Future directions include validation of these results in a large prospective cohort. Multicentric collaboration is the need of the hour. Value of telephonic pre-test and post-test counseling should be assessed. This is already being undertaken in a current study at AIMS. We should focus on previvors to increase uptake of risk-reducing interventions and identify barriers. Coming to the second abstract, this was published in Nature Communications in 2021. This looks at mismatch repair deficiency and its prediction of response to HER2 blockade and HER2 negative breast cancer. A bit of background. As we know that there is an urgent need for newer targets and treatments in ER positive, HER2 negative breast cancer patients who are resistant to endocrine therapy. We know that activation of HER2 is a mechanism of resistance and a promising therapeutic target. At the moment, IHC and FISH are the approved methods of identification. However, benefits may not be restricted to patients who overexpress HER2 or are FISH positive. It is prudent to identify biomarkers in patients who are supposedly HER2 negative, but may still benefit from anti-HER2 therapy. Defects in MUTL, that is the MLH1 and PMS2 complex, leading to HER2 amplification, is an upcoming promising biomarker. So what they did was they basically analyzed membrane HER2 expression in fulvestrant treated breast cancer cell lines harboring loss of MLH1 and PMS2, and they compared that with controls. They also did a similar analysis on patient tumors from the metabolic and TCGA datasets. They tried to look at why patients who have MLH negative breast tumors have HER2 activation. Then they also looked at response of MLH1, MCF7, and T470 cell lines to HER inhibitors. They used lapatinib and neratinib in this study, along with fulvestrant. This was extended to mice xenograft testing as well as patient-derived xenograft models. Transcriptome analysis was also done to assess HER2 RNA expression after neoadjuvant hormonal therapy and its relation to Ki67. This is the first important graph from this, where they found that almost 25% of patients who have uh, uh, defect in MUTL have a high HER2 RNA compared to only 10% of patients who do not have this defect. And it was important to note that patients who have a loss in MUTL actually have a worse disease specific survival as compared to patients who do not have this loss, who have been previously exposed to endocrine therapy. This is a figure which is showing how the HER2 expression increases on exposure to fulvestrant. Let me just get out my pointer. So as you can see here, in patients who are exposed to fulvestrant, there is a significant increase in the MLH1. In patients who are exposed to fulvestrant, there's a significant increase in percentage of HER2 positive cells when there is loss of MLH1. Uh, this is a similar analysis in xenograft models. RNA sequence analysis of these cell lines also showed that basically it is because of inhibition of lysosomal trafficking that this HER2 expression overexpression is seen. These figures basically demonstrate that in patients who have uh, HER2 overexpression, uh, when they are treated with a combination of fulvestrant and lapatinib, they have maximum growth inhibition. As you can see here, these are the points where cell lines have been treated with both fulvestrant and lapatinib, and they have maximum growth inhibition. These are similar findings in a xenograft model. Uh, these are findings in the patient-derived xenograft models. The previous ones were mice-derived xenograft models. And they show a significant inhibition of luminal PDX models compared to basal-like PDX models, which is expected because luminal PDX models are more likely to be hormone expressing. So as you can see here, they are more sensitive to inhibition by fulvestrant and lapatinib. Basal-like are not. And here, this graph basically shows that uh, the loss in MUTL as well as HER2 expression correlates better with key 67 after response to neoadjuvant AI rather than at baseline. Conclusions from this study include MLH1 and PMS2 downregulation could, in theory, constitute as a predictive biomarker for response to HER2 inhibition in endocrine therapy resistant ER positive HER2 negative breast cancer. Loss of MLH1 and PMS2 is associated with poorer outcomes and higher proliferation among ER positive breast cancer. And this makes it clinically relevant and worth further investigating. The mechanism underlying HER2 activation is through lysosomal protein trafficking, and this provides avenue for research to target HER2 in other tumors having loss of MMR by virtue of MLH1 and PMH2 loss. My take on this is that it's an interesting preclinical evidence of possible application of anti-HER2 therapy in ER-positive breast cancer. This demonstrates a unique role of MUTL complex in modulating HER2 expression in ER-positive breast cancer. It also signifies a differential role of different MMR proteins, something which we have not seen previously. Prevalence of MUTL loss needs to be defined in future studies. In this study, they quoted a percentage of 15 to 17%, but this may not be reflective of true prevalence. From the previous TCG and bioportal data, we know that only 3 to 4% of breast cancer patients actually have MSI. And although the correlation of MSI and MMR in breast cancer is not good, we still need to understand the exact prevalence of MMR by uh, MLH1 and PMS2 loss. Uh, the clinical aspect of this would be if this gets validated in further studies. We know that immunotherapy works in patients who have deficient MMR. So IO versus anti-HER2 for patients with this uh, MUTL loss in clinic will be a challenge if this is validated. Uh, as I said before, lack of correlation between MMR and MSI in breast cancer further complicates this decision-making process. And further studies with more potent TKIs and more clinically efficacious TKIs like tucatinib may be more promising and something worth exploring. Thank you for your attention and stay safe.